Well, good afternoon, everyone. It didn't take me long to realize your meetings are definitely cooler than ours. This is a fun spot you guys have here. Rick, I don't know where you are, but thank you for the invite. I truly am honored, and thank you all for having an ENT among you. I definitely feel like I stick out. So unfortunately, I literally just got here, so I missed all of the talks before this, but looking at the talk titles, I assume there's a good bit of interplay with what I'll be talking about, so hopefully this can be a good addition to that. And yes, I do recognize this is your last session, and I'm sure you're all tired. So I'll try to be brief, but I really am fine with, I don't know how y'all have been doing it, but if you have questions or comments during it, please feel free to raise your hand. Okay, so when Rick asked me to send in my talk details, I actually was really struggling to think of a good name for this title, or for this talk, and in one of our emails I mistakenly got the impression from him that I should name it this. So I was pretty embarrassed when I figured out a few days ago this was the name of the entire theme of the meeting. In an effort not to make myself a self-appointed keynote speaker, I asked our good friend Chat GPT for a different answer, or a different option, and this is what it came up with. And I thought that was pretty good too. So here's my new title. And in full disclosure, that's about all. ChatGPT helped me with this, despite my best efforts. I really wanted to just make the whole slide deck, but it couldn't deliver on that. So for better or worse, the rest of this will be original. And that's about my only disclosure. So before we jump in, I just want to give a roadmap of where we're headed over the next few minutes. And so recognizing that we all share a lot of knowledge about the structure and function of the oral cavity, I'm kind of just leaving that out completely. And I want to focus on some airway disorders that are beyond that point, and I really want to try to use that discussion to highlight the role that airway dynamics play in the symptoms, but also in the way we choose to evaluate those symptoms. And then I'll take a few minutes to discuss the benefits and drawbacks of the various ways we evaluate. And to wrap it up, just a few words on why this calls for collaboration among us. All right, well, given that airway surgery is a large portion of what I do, trying to distill a talk about that into a few minutes has felt really daunting since the first time Rick asked. And there's definitely been a little part of me that was like, that would be kind of like us inviting a dentist to an ENT meeting and say, talk about teeth, just broadly. So Rick has been very kind in helping me navigate what will hopefully be most high yield for you guys. And I really think just these simple diagrams hint at just how many different things we could try to cover here, from the tip of the nose all the way down to the alveoli. But for the sake of time, I'm just going to also leave out pretty much everything nasal cavity and nasopharyngeal, and everything basically bronchioles and on to the lungs, because as it is, throat to trachea is still a ton. But that does pretty much sum up where we spend most of our time, and also is a great place to kind of highlight some of the dynamics of the airway. And I thought the best way to do that, hopefully especially when it's late in the afternoon, is just with a couple of case studies. So this is something we all see. Here's a 5-year-old male. He comes into the clinic, and I should say these are not actual patients of mine, but they're so darn close to an amalgamation of all of them that it could easily be someone we see any day. So we'll start with this 5-year-old boy. He comes in, and his parents say he's been snoring like a grown man since he was born. He never had a sleep study initially, but around age 3, he got his tonsils and adenoid out. That helped for a little while, and then over the past year or so, his sleep symptoms have worsened quite a bit. Usually for us, at that point, if they've already kind of had the low-hanging fruit addressed, then we will get a sleep study. So he gets a sleep study, and he has severe sleep apnea. On exam, there's nothing really that sticks out. He's not obese, which is shocking for some of these kids. Orthognathic, his palate's normal. The front of his nose is pretty open. So we discussed the options with the family. Do you want to try CPAP, or do you want to try a surgery? And like 99% of parents in that situation, they're pretty sure their kid's not going to wear a mask every night. So they decide we're going to do surgery. And that is started by and guided by this procedure, drug-induced sleep endoscopy. And I don't know how many of you are familiar with DICE, but it is just a long name for a very short procedure, which we do a lot to make us feel better about ourselves. So it's basically passing our little scope through the nose down to the larynx, but while they're in a hopefully state that's mimicking sleep. And that's honestly where the complexity of what is technically about a 1-minute procedure lies, because for anesthesia, we really do want them to try their best to mimic what natural sleep obstruction would look like. And the obstruction part is really what gets them too, because their natural tendency is to try to alleviate that, but they're sitting on the OR bed, SATs are dropping, and we're just looking with our scope to see why that might be. And I'll get into this a little bit later, but you can see even from those pictures on the side there that it helps us see a lot of different levels and the dynamics that might be going on there. So for the sake of this patient, what we saw was actually really big lingual tonsils. Now, most of our patients don't even know there are lingual tonsils, and if that comes up, they're like, I thought we already took out the tonsils. So this is not actually that uncommon, that they can be really big like that. And if you can see, let me see if this pointer, is it working? Yeah, so, and they're so big that it's basically, you can barely see the epiglottis there. Everything's being pushed back by these tonsils. And we can often tell with this, it's not actually glossoptosis, it's just that those tonsils are so big. So in this case, at the same time as the DICE, we'll move on and remove the lingual tonsils, usually endoscopic assisted, and then, hopefully several weeks later, and a lot of times, that will help resolve it. All right, so here's a second one. So this is a 4-year-old girl who came into the ED, middle of the night, sudden onset of stridor, significant retractions, and having the barky cough. And she's had episodes like that before, ever since she was a baby, but this was one of the most severe. Parents are used to trying cold air or steam, and this time it just didn't help. So they go to the emergency department, get some Decadron, racemic epinephrine, and fortunately did not have to get admitted. A lot of times that'll help the kids turn around. They've typically been able to manage her episodes at home, which happens several times a year, but one time she did have to get admitted when she was a baby, and she was found to have RSV that time, and there's a lot of coincidence of those two. But after recovering from this episode, given that it was more severe and given the history you see here, she was sent our way. And a lot of times they're sent to us just to kind of help figure out, is there something about the airway that's leaving them more prone to what might be a cold for another child becoming croup for this child. And maybe that's a situation you guys have been in with any of your children, I don't know. But we will typically not scope one of these patients like in the throes of one of these episodes. That'll just potentially push them over the edge. But so this right here is a picture of what it would look like if we did. And the x-rays are a more common thing that are done at that time. And does anyone know what that is? The name, any of this condition? It's croup. It's croup. And a lot of kids get this. The full name of it, which is actually probably more accurate, basically highlights how it's basically inflammation of the entire airway. Larynx, trachea, bronchi, everything's inflamed. And just like that endoscopic picture there, it really is typically a mess. So a lot of times once they come to us, we're trying to help decipher, is this someone that should even go to the OR to help figure out if they have an underlying airway abnormality that could cause this. And so most kids actually don't need that. Most kids, we won't find something. She has enough risk factors that it would have been worth looking. And these are 3 of the common things we might find. This top one is laryngomalacia. I just had a case of that today. But if you look at the left side, that's what a normal larynx should look like when we've put our laryngoscope in there and we're looking straight down. Same view your anesthesiologist should get when they're intubating. But then a laryngomalacia kid will have all that just curled up epiglottis, and the arytenoids tend to be very floppy as well, and you can barely see the laryngeal inlet. This is a static picture, but this is a condition that is much better appreciated when it's dynamic. Another problem that this patient might have is subglottic stenosis. So that's basically kids who have been intubated for a long time, can get scarring in that area right under the vocal cords, and that's honestly can be a pain to deal with. Those kids often need a lot of endoscopic procedures to sort of break the cycle of scarring, sometimes even an open airway reconstruction to augment the diameter there. And then, of course, there's other malatias. There's tracheomalacia, bronchomalacia. Just like laryngomalacia, most of these things are things that kids will outgrow as they get older. But there are the rare exceptions that do end up needing surgery. When kids need a laryngomalacia surgery, that's a pretty easy 15-minute endoscopic thing. Tracheomalacia, bronchomalacia, that becomes a lot more complicated. The typical sort of classic treatment for that has just been to do a trach. But some of these kids now are getting tracheopexy procedures where they basically try to suture the floppy part to something firm in there, like the spine or the sternum, depending which way they're going. I say they because that's mostly like a chest surgeon type thing, not really ENT. We'll do it if that floppiness is higher up and accessible through the neck. Any questions so far? All right. Well, kind of moving on from those, I think no airway dynamics talk would be complete without this obligate nod to Poiseuille. So I know you all know this, and some of us may have to reach back a little bit, but basically, takeaway is little changes in radius make a big change in airflow, right? And I literally saw that twice today in the OR, and I kind of was laughing about having this talk coming up, because when I did, just to go back, like a laryngomalacia patient today, the little snips we make and little bit of tissue we take out, it's tiny. Like if you brought it out, it's barely your pinky nail, but it makes a big difference for the kids. And I think where we actually see this the most pronounced is in cases of subglottic stenosis, because sometimes even just what we call a grade 1 stenosis, so under 50% narrowing, that can have a profound impact on kids, especially when they're younger. Similarly, if we stick a little balloon in there and dilate it, it can be amazing until it scars again. We'll leave that for another talk. This is just, I thought, a really helpful, this is actually one of many grading protocols for a DICE, or the sleep endoscopy I was talking about. And I thought it's a lot, I get that, but I thought it was really helpful because it highlights some of these features of an airway, right? That it's collapsible, it's pressure sensitive, some change in one part will change the dynamics in another part, and it definitely changes with sleep and of course other situations too. And that often obstructions can be multi-level. So I thought this was a nice thorough one, so I just wanted to highlight a couple things. All the top row there, that's supposed to be basically different potential views of the velopharynx, and I know a lot of you work in that area as well, but you can tell, and you're used to it too, that there's a lot of different patterns for how that could be obstructive, almost always a dynamic thing, right? Not usually just a static structural thing. Of course, cleft palates are an exception, but the next part, level, if you can even see those little letters B, that's at the oropharyngeal level. And again, in these pictures, we don't even have much in the way of tonsils, but sometimes what I describe to the families is if the tonsils and adenoid are like things coming off the wall, sometimes the walls themselves are caving in, and that's a much different picture for us because that's not an easy surgery. We see that primarily in kids with neuro abnormalities and things like that, but it does happen. The next row then is at the tongue base, and again, I know a lot of you work with things that can certainly help that type of obstruction, but that one, if you look at the farthest grade 4, you can see how much that's impacting our view of the larynx. D, the next row, is supposed to be basically showing different positions of the epiglottis, which does often correlate with the tongue base, but not always. Sometimes the epiglottis is just doing its own thing and can be super annoying. And then that's, I think, what E is supposed to be, another picture of that. And then finally F is the arytenoid, so the back part of the larynx, how they are folding over, kind of like we talked about with the laryngomalacia. So how do we assess the airway? There's a million ways, right? Like we all do this all the time, just a clinical exam. And then we have all kinds of imaging, ranging from plain films to you're all's fancy like CTs with the coloring. I like that. And then now, I mean, and I don't know if some of you have access to this type of stuff, but Cine MRIs, I think there are Cine CTs too. I'm not sure that we're doing many of them in Charlotte, honestly, but basically that's a video MRI. So it's designed to try to overcome what can be a knock on imaging in general, is that this is trying to also capture some of the dynamics. Some of our workhorses we've already kind of hinted at, but the flexible scope, that's something we'll do, you know, a dozen times in a clinic day. Kids love it every time. Parents do too. The next one, that's a picture of a rigid bronchoscope, which is obviously requires anesthesia, but has its own advantages we'll get to in a second. And then the last picture is obviously something that, well, actually, I don't know, are there any sleep medicine folks here? So that's a kid getting a sleep study, and they're always just curled up nicely like that, you know, enjoying all their leads. But that can be a really helpful adjunct to what we all do, right? That's one of the few ways we can quantify things. So if we kind of break that all down, right? Like how do we know, like, which to use? So physical exam, obviously it's going to have its benefits. It's immediate, it's essentially no cost, but it's also very limited. And is everyone here working with peds primarily, I assume? So you know that's going to be very much dependent on how they feel that day. If we look at x-rays and CTs, now we're getting the benefit of some structural definition and abilities to quantify things, like I said with the CTs. Of course, the knocks on that would be that it is static, there's radiation exposure, and there's some cost. I felt like I was like Google with restaurants with all these dollar signs here. MRI, so there's a different, obviously you all know the whole soft tissue bony thing, but MRI is going to help us with soft tissue definition. It has the benefit of no radiation, but kids, in my practice at least up to about 6, are going to need anesthesia, and that's obviously the big downside of that, as well as $3 signs instead of 2. We talked about the sleep study. It's one of the few things that can give us quantifiable data, but it is time intensive. A lot of people do not enjoy it. And it's obviously not site specific, so it'll tell us if there is an obstruction, but then we still need to figure out where that obstruction is coming from. Flexible scopes we like because it's a real-time eval, a direct view. It gives us the dynamics, and it does allow us to do things like a DICE, but patients do not like it. In clinic, it takes about 15-20 seconds, but it's usually 15 or 20 seconds of screaming. And then rigid scopes, for us, are just obviously mostly reserved for when we need to look at something beyond the level of the vocal cords, which is about as far as we can safely see. In the clinic, there are a few cowboys out there who go past there, but you do risk laryngospasm, and I don't want to deal with that personally. It also allows us to do possible interventions, foreign body removals, dilations, things like that. Of course, the big problem there is that it requires anesthesia, and actually because of that anesthesia, it's not as good of a dynamic assessment as the flexible scope because we can't do it awake, and so sometimes it really is a fine balance for anesthesia to make them deep enough that we can stick a metal rod in their airway, but light enough that we capture things like when their breathing is malasic, like in the trachea. So all that, of course, begs the question, well, how do we know which methods to use and when? And obviously we already do this, but we use our clinical judgment based on the problem we're seeing, the kid we're seeing. And as I've tried to highlight today, hopefully we can also always keep just the dynamics of the airway in mind and how we can best capture that. And then as we all know, many of these patients may have multi-level obstructions, so they're probably going to potentially need multimodal approaches, multiple of the things on the chart that we just discussed. So just to wrap it all up, and at risk of having a kumbaya slide here, I think the sort of unspoken thing, of course, is right. There's a lot of overlap between our practices sometimes, and maybe even some tension. And I don't think any of us is immune to that. But at the same time, it doesn't have to be that way. Because we share some of the same goals with not just ourselves in terms of helping kids breathe better and live healthier lives, but with all these other specialists that also have a stake in this, pulmonologists and GIs and sleep medicine folks, and I think there are some speech therapists here, right? And OT and PT. So keeping in mind kind of all of those folks who have something to say about this, keeping in mind their scope of practice and their expertise, recognizing that, and of course just being good communicators with each other, with our patients about what to expect of the others and that kind of thing. And that's basically it. Questions? Yes?
Which office do you practice in?
South Park. Yes, yeah. For better or worse, there's two of us who are pediatric ENTs exclusively, and we're both at South Park. Darren Ban is the other, if you've heard that name. That's it. That was an easy one. Okay, thank y'all.